Welcome! Today we're going to conduct a meticulous examination of the prophylactic strategies that are absolutely critical following a solid organ transplant.
Let's dive in by acknowledging the central conflict here, which this quote captures perfectly. A successful transplant is, without a doubt, a monumental achievement. But it immediately throws us into this incredibly delicate balancing act. We have to suppress the immune system enough to stop organ rejection, but not so much that we open the door to a devastating infection. That's the tightrope we walk every single day.
So, here's our roadmap. We'll start with the why, that core conundrum. Then we'll build the foundations of a good strategy. From there, it's into the specifics: antibiotics, antifungals, and antivirals. And we'll wrap up with a quick knowledge check to make sure it all clicks.
So first up, let's unpack this conundrum. Because to really understand the solutions, we have to have a deep respect for the profound risks that necessary immunosuppression creates.
And this, prophylaxis, is our primary strategy. It's a preemptive strike. We're not waiting around for an infection to happen. We are actively using medications, vaccines, and immunoglobulins to build a shield and prevent that infection from ever taking hold in a highly susceptible patient.
So, what does a good prophylactic strategy actually look like? Well, it's not just throwing drugs at a patient. It's governed by a set of core principles, really the fundamental rules of engagement. An effective strategy is built on a few key pillars. First, you have to cover the usual suspects, your Staphylococcus aureus from the scan and your gut Enterobacteriaceae. For some procedures, you'll need to add anaerobic coverage. Simplicity and consistency in protocols are also paramount because that reduces the chance of error. And this one is absolutely crucial. You intentionally use agents for prophylaxis that you wouldn't typically use for therapy. Why? To limit the development of antimicrobial resistance. You save your big guns. And of course, this is all developed by multidisciplinary teams.
And this number right here, 60 minutes, beautifully illustrates the most critical timing parameter we have. The antibiotic has to be in the patient's system within this 60-minute window before the first incision is made. That's the key to efficacy. And hitting that target typically falls to the anesthesiologist.
All right, let's move from principles to practice. Let's see how these rules are applied to specific antibiotic regimens right there in the operative setting. Let's take a standard kidney or pancreas transplant as our case. The protocol follows a very clear, time-sensitive sequence. You start with 2 grams of cefazolin IV, right in that pre-op window. But you've got to be dynamic. If the surgery runs long, over 4 hours, or if there's a major blood loss of more than 1.5 liters, you've got to repeat that dose to maintain therapeutic levels. And you continue dosing for the first 24 hours post-op.
Now here's where it gets really interesting, because the protocol has to be able to adapt on the fly. For a standard liver transplant, it's 24 hours of cefazolin. Simple enough. But what if there's a spill? If biliary or gut contents contaminate the surgical field, the whole game changes. The standard protocol is out. You immediately pivot to a much broader 5-day course of cefuroxime plus metronidazole to cover the much wider range of pathogens, especially the anaerobes that have just been introduced.
Okay, so we've covered bacteria. Now we need to shift our focus to fungi. And here, the approach is fundamentally different. Risk stratification is the name of the game. We're not giving these agents to everyone. It's all about pinpointing who is at high risk and truly needs the intervention. In a liver transplant, these are the red flags you're looking for. The presence of even one of these factors, renal insufficiency, the need for retransplantation, a massive blood transfusion, it significantly elevates the risk of invasive mycoses. And that's your trigger. That mandates prophylaxis, typically with an agent like fluconazole.
The choice of which antifungal agent to use is, well, it's complex. This data from key studies highlights the constant trade-offs. For example, look at posaconazole versus fluconazole. You get a reduction in invasive aspergillosis and a reduction in mortality. That's a huge win. But then you look at itraconazole. It also reduces aspergillosis, but at the cost of more adverse events. These are the tough, nuanced decisions that have to be weighed for every patient.
And finally, let's turn to viruses. Here, our strategies range all the way from pre-exposure prevention, stopping it before it happens, to urgent post-exposure treatment after the fact.
Now, it is absolutely essential to distinguish between PrEP and PEP. They are not interchangeable. PrEP, pre-exposure prophylaxis, is a preventative measure for HIV-negative individuals at high risk. You use antiretrovirals to stop an infection from ever taking hold. PEP, post-exposure prophylaxis, is an emergency intervention. It's for use after a potential exposure, like a needle stick in the hospital. It's an aggressive, 4-week, 3-drug course that you have to start within hours.
And that timeline for PEP is absolutely unforgiving. You can see it here. The optimal start time is less than 2 hours. The maximum delay before it's considered ineffective is 72 hours. Treatment has to begin as rapidly as possible. Every single hour counts. It's a true medical emergency.
Okay, that was a pretty dense overview. So, to consolidate this material, let's engage in a brief series of clinical questions to assess our understanding.
First question. Consider your first-line choice. Which antibiotic is frequently recommended for standard perioperative coverage against S. aureus and Enterobacteriaceae?
The correct answer is C, cefazolin. It really is the workhorse agent here. It's a first-generation cephalosporin, and its spectrum is ideal for covering the most common surgical site pathogens. The other agents are certainly useful, but they're reserved for specific therapeutic situations, not for routine prophylaxis.
All right, next question. Let's recall those factors that escalate a patient from low risk to high risk for invasive mycoses. Which of these is a key risk factor in liver transplant patients that would necessitate prophylaxis?
And the answer is B, retransplantation. This is a crucial point. Undergoing a second transplant procedure is, in itself, a major independent risk factor. It's one of those key markers, along with things like renal insufficiency or massive transfusion, that demands our attention and triggers the need for prophylaxis.
In our final question, think about the strategy for preventing an infection before any potential exposure has even happened. For an HIV seronegative individual who is at high risk of infection, which prophylactic approach do we recommend?
The answer here is D, pre-exposure prophylaxis. PrEP is that proactive strategy, using antiretrovirals to prevent HIV acquisition in the first place. It's a cornerstone of modern HIV prevention, and, as we've covered, it is fundamentally distinct from PEP, which is that reactive, emergency measure.
So I'll conclude with this final thought, a question that really frames the entire post-transplant journey. For a patient who is on lifelong immunosuppression, where does prophylaxis truly end and chronic maintenance begin? The honest answer is that the line becomes incredibly blurred. This isn't a finite course of treatment. It is a continuous, lifelong reevaluation of risk and benefit, that delicate, perpetual balance between preventing rejection and preventing infection.